So adjuvant therapy for non-small cell lung cancer, meaning systemic treatment that we give after surgery in an attempt to decrease the risk of relapse and death from lung cancer, has not always been a thing. So in 1995, there was a meta-analysis that put together the randomized studies to that point, and overall there wasn't much of a benefit with the alkylating agents that had been used previously. But when they just looked at the cisplatin-based chemotherapy studies, there was a very small benefit of about 5% for patients who got cisplatin-based chemotherapy after surgery for their lung cancer in terms of overall survival. So that's what led to the first study that really put adjuvant therapy on the map, and that's the YALT study, where patients with surgically resected non-small cell lung cancer were randomly assigned to sort of old-school cisplatin-based chemotherapy with either etoposide, vinorelbine, vinblastine, or vindicine within 60 days post-op versus observation. This was initially presented in June of 2003. And when initially presented was exciting because it was statistically significant in terms of a survival advantage with a hazard ratio of 0.86 in the initial publication in the New England Journal. But that amounted to only a 4.1% absolute benefit at 5 years. So our thoracic surgeons at Penn at that time, when I was there, were very underwhelmed and were not thrilled about sending patients to see me for a discussion about whether or not they wanted a treatment that offered a 4% benefit. But I did have that discussion and started treating patients based on that study. With additional follow-up, however, in the YALT study, it actually lost its statistical significance. There was a bowing of the curve. So while about 5 years, yes, there was a small benefit to chemotherapy, that benefit goes away with time, and the hazard ratio went down to 0.91 with 7.5 years follow-up, and that was not a statistically significant advantage. Now, another study that came out a couple years after the YALT study was the NCI BR10 study, and this took patients with just stage 1B through stage 2 non-small cell lung cancer, 482 of them, and they were randomly assigned to just one chemotherapy regimen, cisplatin and vinorelbine, versus no chemotherapy. And this study looked a little bit better. The absolute improvement in 5 years in overall survival was 15%, from 54% to 69%. So this was a little bit more exciting that this is actually something that is offering our patients benefit. And with additional follow-up, the survival has not remained as robust. The 5-year overall survival has gone down to 11%. But the benefit has persisted beyond 9 years and still maintains statistical significance with a hazard ratio of 0.78. So this is a more robust study supporting the use of adjuvant platinum-based chemotherapy. There were other studies in the mix at this time, some negative, some mildly positive, that were included in an updated meta-analysis of platinum-based chemotherapy. This was the LACE meta-analysis, 5 trials of over 4,500 patients. The majority of these patients were male, 80%. They were mostly pretty young. Median age was 59. Only 9% were over 70 years of age, and that contributes to the fact that we often don't know exactly what we should be doing with elderly patients because they're underrepresented relative to what we see in lung cancer. Also underrepresented were the stage 1As. Only 8% of those patients had stage 1A. And a decent number of patients, more than we might expect now, had a pneumonectomy. About a third of patients underwent a pneumonectomy rather than lobectomy. And again, these are older studies where squamous cell was still the predominant histology at 49%, versus now we tend to see more non-squamous. In any case, you put it all together, and there was indeed in these studies an absolute benefit of chemotherapy at 5 years of 6.9%. Now, interestingly, and this speaks to why the LACE meta-analysis lost its positivity, so chemotherapy is good for you if it cures you of your lung cancer. If you weren't going to die of your lung cancer, it's actually not very good for you. So while there was an improvement, a decrease in the risk of death from lung cancer, there was actually an increase of 1.4% for risk of non-lung cancer death. So that's shown on the far curve, that you are more likely to die of something other than lung cancer if you got chemotherapy, but a little less likely to die of your lung cancer. Now, lung cancer is such a huge risk that means that overall the chemotherapy is beneficial. So these are the studies that were included in the LACE meta-analysis, and they're broken down for overall survival as well as disease-free survival, and you can see which ones offer benefits. So for overall survival, the hazard ratio was 0.89 versus disease-free survival 0.84. So these studies all support there is a small but real benefit to adjuvant cisplatin-based chemotherapy. And this, of course, has made its way into recommendations both from ASCO, and this is the current NCCN guidelines. For stage 1A disease, however, there was an actual risk, increased risk of death with chemotherapy. So for stage 1A disease, the recommendation is that these patients should be observed and should not get chemotherapy because that risk of chemotherapy not being good for you exceeds the benefit because you're less likely to die of your lung cancer if you have stage 1A disease. For stage 2 or stage 3 disease, it is clear that these patients ought to be getting adjuvant chemotherapy. For 1B, you'll notice in that second column that it says that you can either observe or give chemotherapy for quote-unquote high-risk patients. So that gets a little bit tough to interpret. The caveat is down here at the bottom. So the examples of high-risk factors include poorly differentiated tumors, including lung neuroendocrine tumors, and actually I'll be speaking to that later, excluding the well-differentiated neuroendocrine tumors, vascular invasion, a patient who just went a wedge resection instead of a lobectomy or an anatomical segmentectomy, tumors greater than 4 centimeters, visceral pleural involvement, or unknown lymph node status. So none of these individually say you should be giving chemotherapy, but they're factors you can weigh into whether they're at increased risk with their 1B disease of dying of their lung cancer, and therefore the benefit of chemotherapy is more likely to exceed the risk. So where does this recommendation come from? It does come from a breakdown of the LACE meta-analysis, and I'm showing here by stage. Remember, only 8% of the patients had stage 1A disease, but of those patients with 1A disease, whoa, I didn't even do that. Something is happening. All right, of those patients with stage 1A disease, they were more likely to be deceased. The hazard ratio was 1.41 against chemotherapy, whereas for 1B, breaks even at 0.92. It's neither helpful nor harmful, but the clearer benefit lies in the stage 2 and stage 3 patients. There have been additional meta-analyses that have been published. There was a Cochrane review done that included not just the platinum-based chemotherapy, but also non-platinum-based chemotherapy adjuvant studies. A lot of the Japanese studies used 5-FU-based therapies. And there were over 8,000 patients, and that confirmed that there was a hazard ratio of is this on a timer? Seems to keep advancing without me. Hazard ratio of 0.86. So 0.86 overall, and there was no difference in the benefit for stage 1B patients. If you look down here at the bottom, once again we see that the stage 1A patients were more likely to be harmed, but in this analysis, which included more adjuvant studies, while it was not statistically significant, at least the trend for the 1Bs was of a similar magnitude as that for stage 2s and 3s. So this kind of calls into question, and is a little bit why it's a little bit of a fuzzier recommendation when it comes to the 1B patients, whether or not we should be giving chemotherapy. These are some of the studies included in the LACE meta-analysis with the addition of the CLGB adjuvant study, which was a study of adjuvant carboplatin and paclitaxel, not cisplatin-based regimen. And these were studies that included stage 2 and 3 patients, as well as 1B patients. And when you look at an analysis that broke down the tumors by size within the 1B category, 2 of the studies, the BR10 study, that was the cisplatin vinorelbine one I showed you that initially had the 15% benefit, and the CLGB study, the adjuvant carboplatin and paclitaxel, actually showed that it was the tumors greater than 4 centimeters that had statistical benefits from adjuvant chemotherapy, and those that less than 4 centimeters did not. So a lot of current protocols are written such that adjuvant chemotherapy is recommended for greater than 4 centimeters than less than 4 centimeters. That was one of the factors in the NCCN guidelines that you could consider, and in my practice, that's the main one that I consider because it has, again, this is a retrospective evaluation. These are not prospective design studies looking at size, but it's the best evidence for supporting that that's the high-risk factor that adjuvant chemotherapy can impact. Here's another retrospective review. Now this one was a very large review of over 25,000 patients who were all T2 and 0, and this is from the National Lung Cancer Database. About 20% of these patients underwent adjuvant chemotherapy. In this study, they actually found that all the 1Bs benefited in terms of getting adjuvant chemotherapy, that people who got adjuvant chemotherapy did better than those who didn't, regardless of the size of the tumor. And what we have here are the curves for 3 to 3.9 and then 4 to 9.9. So if you see the 3 to 3.9, they benefited from chemotherapy. But remember, this was a retrospective study, so your patients getting chemotherapy more likely to be better patients, and indeed they were younger, more likely to have larger, higher-risk tumors, and less likely to have undergone a sublobar resection. So they were patients who were already in a better position to do better. So provocative, but not definitive for chemotherapy being beneficial in smaller tumors. Now going beyond chemotherapy, one such attempt was bevacizumab, which was the drug that was all the rage, before TKIs and immunotherapy. And this is the schema for the ECOG study 1505, where patients with resected stage 1B to 3A disease, and this again has the greater than or equal to 4 centimeter statement in it, were all received platinum-based doublet chemotherapy, but were randomly assigned to receive bevacizumab along with that chemotherapy, with the bevacizumab continuing for a year versus the chemotherapy alone. The investigator could choose the chemotherapy. We had the cisplatin vinorelbine, which was the most represented in the earlier studies, or cisplatin docetaxel, cisplatin gemcitabine, and in the non-squamous patients, cisplatin pemetrexed was allowed. This study was completely negative. There was no benefit to bevacizumab in either overall survival or disease-free survival, so unfortunately a negative study, and we weren't able to improve on patient outcomes. Interestingly, though, this study did allow an analysis of the different chemotherapy regimens, and there was no difference in terms of disease-free or overall survival for the different chemotherapeutic regimens, supporting that any of those are reasonable to use in our patients. It did also allow a look at the toxicity, and it was not really surprising to those of us who use a lot of these chemotherapies. Bevacizumab increased the risk of neutropenia and hypertension, as well as the worst grade of 3 to 5 toxicities, but there was no difference in grade 5 AEs. For the chemotherapy regimens, vinorelbine was more likely to lead to neutropenia and febrile neutropenia, gemcitabine more likely to lead to thrombocytopenia. Within the non-squamous category, the risk of grade 3 to 5 toxicity was least in a statistically significant way for cisplatin pemetrexed over the other regimens that were used. So there is a difference in toxicity, did not appear to be a difference in efficacy. This is actually being evaluated directly in a Japanese intergroup study that is directly comparing cisplatin and vinorelbine, which many people consider standard for adjuvant therapy since it has the wealth of the data, versus cisplatin and pemetrexed. And the primary endpoint is looking for overall survival, which I'm not sure that that's going to be achieved by cispem, but at least maybe this will establish that it really is an easier regimen that appears equally efficacious. So now getting into EGFR TKIs. This has been looked at for a while in the adjuvant setting. The initial study was the BR19 study, which looked at adjuvant gefitinib in an unselected patient population. These were patients with 1B through 3A disease who underwent surgical resection. The study actually started before adjuvant chemotherapy was established, so they could get it or not get it. So there was over 1,000 patients, and they were randomly assigned to gefitinib for 2 years versus placebo. And there was no difference in terms of disease-free survival or overall survival in support of those patients getting gefitinib. Now, we now know that these EGFR TKIs work best in particular patients. They work best in patients with EGFR mutations, so perhaps that's the problem, that this was an unselected patient population, and we need to focus in on the EGFR mutation patients. Now, this study did not have a lot of power to do that because there were only 15 such patients that they found, but it did actually not show a benefit for patients with EGFR mutations, and in fact, the trend is for worse overall survival for these patients. But again, 15 patients, so hard to make any conclusions. And maybe gefitinib is not the best drug anyway. If we remember in the second and third line studies, erlotinib actually showed a survival benefit for unselected patients, but gefitinib did not in the ISIL study. So maybe that means this RADIANT study has a better opportunity to show a benefit to an EGFR TKI. In this study, patients were randomly assigned to erlotinib for 2 years versus placebo. And this was actually what should have been maybe an enriched population. They weren't completely unselected. They had to be FISH positive or immunohistochemistry positive for EGFR. Remember, this is not the same as an EGFR mutation. This is just expression on the surface of the cell of the EGFR protein. So the primary endpoint was disease-free survival. Once again, what we have here is a negative study. There was no advantage in disease-free survival. However, if we looked at the EGFR mutation-positive subgroup, 161 such patients this time, they actually did have a dramatically improved disease-free survival if they got erlotinib versus placebo. However, if we look at what has so far presented have been immature results of overall survival, there is not really a glimmer of overall survival benefit to getting erlotinib for the EGFR mutated patient population, nor the original intent to treat population either. So there are other studies that have looked directly at the EGFR mutation patient population. This is one we were involved in Penn, a phase 2 study of adjuvant erlotinib in patients who had EGFR mutation stage 1A through 3A. They could have gotten or not gotten adjuvant chemotherapy. 100 patients were enrolled in 7 sites. The erlotinib was well tolerated, but 40% of patients did undergo a dose reduction. The median time to recurrence was 12 months after stopping the drug. Patients who stopped the drug underwent repeat biopsy, and interestingly, patients who recurred after stopping, only one of them had a T790 mutation, suggesting that patients did not recur because they were resistant to the erlotinib, but because they'd stopped it. And to that end, 70% of the patients were retreated with erlotinib, and 10 were able to remain on it. So if we look at the disease-free survival, it looked pretty good for historical controls, but if you look at the 2-year drop-off, that's when they stopped the drug, it seems like a lot of recurrences happen after 2 years, suggesting maybe that this drug is just kind of keeping things at bay and not keeping the cancer from coming back, just coming back from when you're taking it. So this gets to now the Adjuvant study presented by the Chinese Thoracic Oncology Group at ASCO this year. These were patients with completely resected node-positive disease, stage 2 or 3A, N1 or N2, who had EGFR activating mutations, specifically exon 19 or exon 21 mutations. And they were randomly assigned not all to a standard of care arm. They got either chemotherapy with cisplatin and venetoclax, or they got gefitinib, 250 milligrams a day for 2 years. And the primary endpoint was disease-free survival. Now, in fact, this was a very positive study. The disease-free survival was improved for those patients getting gefitinib over those patients who got chemotherapy, with a median survival of 28.7 months versus 18 months, so the hazard ratio of 0.6. But the overall survival data is not available yet. It's immature, so we don't know if there's an overall survival benefit, and that's important because look what happens at 3 years. There is a coming together of the curves, suggesting that the benefit to erlotinib seems to be, or to gefitinib, is primarily while the patients are taking it. So are we curing these patients, or are we just keeping their cancer from appearing while they're taking the drug? And that's not clear. And remember the commitment. These patients need to take this drug for 2 years versus just being on chemotherapy for 4 cycles. It's expensive. It does have side effects. Overall, the toxicity was better tolerated for patients taking gefitinib over chemotherapy, but it's a more prolonged toxicity. So this is what we have now that hopefully is going to answer these questions better, and this is the Alchemist trial, a trial designed specifically to look at whether targeted therapy in the adjuvant setting has an overall survival benefit. Patients are screened for either an EGFR or an ALK mutation, and those who have the mutation undergo the targeted agent for 2 years to see if there's an improvement in overall survival. Patients who are screened and not eligible can go on to an immunotherapy arm that I'll talk about in a second, which is right now. So immunotherapy, that's the next horizon in adjuvant therapy. Why? Well, we're going to be hearing a lot about this later, but we know the KEYNOTE-24 study that showed in high PD-L1 patients in the metastatic setting, they had a survival benefit to pembrolizumab versus chemotherapy, and then the combination of chemotherapy plus pembrolizumab had an improved disease-free survival and a very provocative overall survival benefit for patients when pembrolizumab was combined with chemotherapy in non-squamous patients. So the ANVIL portion of the Alchemist trial that I just showed you is actually looking at adjuvant nivolumab for 2 years after patients get their adjuvant chemotherapy versus standard of care and looking for an overall survival benefit. There's also the PEARL study, which is looking at a potential advantage for a year of pembrolizumab in surgically resected patients with a primary endpoint of disease-free survival. Switching gears a little bit to something else we can do to patients postoperatively, which is radiation therapy. Radiation therapy after surgery for lung cancer got a bad name with the Port meta-analysis in 1998, where they showed that there was actually a survival decrement with a hazard ratio of 1.21 for those patients who got adjuvant or postoperative radiation therapy, and the risk was higher for those patients with early stage disease, stage 1 or 2 versus 3. This is the survival curve showing that patients who did not get postoperative radiation actually did better than people who did. If you look at the stage, though, stage 1 or 2 had the worst survival decrement, and stage 3 patients broke even, or those with N2 disease, suggesting that it's patients with the least to gain have the most to lose. If you're not really likely to die of your lung cancer, then you're more susceptible to the toxicity of the treatment, the same thing we saw with chemotherapy. This study itself, though, was flawed in the studies that were selected for it. They were variable, and the staging wasn't specified. The radiation was old-school radiation that was not as safe as what we have now. Why would you include node-negative patients in the first place? So there have been other looks at radiation in this setting. Mitch McTay looked at 200 patients who got postoperative radiation with stage 2 and 3 disease, and I didn't find that there was an increased risk of death from other causes besides lung cancer. There was no signal that radiation was bad for these patients. And then there are other pieces of information to be gleaned from these adjuvant studies. The ANITA study, which was one of those cisplatin-based adjuvant chemotherapy studies I showed you that was in the LACE meta-analysis, actually allowed patients to get postoperative radiation by site. They had to pre-specify what the indication was. So 33% of the patients on observation got postoperative radiation, 22% on the chemo arm. For all the patients, the people who got chemotherapy did the best. That was one of the studies that showed chemotherapy was advantageous. But the people who got radiation in some form, either with or without chemotherapy, did better than patients who did not get any adjuvant treatment. They looked at only the N2 positive patients, the stage 3A patients. Those who did the best were those who got the combination of chemotherapy and radiation. They did better than those who got chemo, and those did better than people who got radiation, and any treatment adjuvantly were better than those patients who got no adjuvant treatment. So these are those curves for that, showing that the best for the N2 patients for those who got the adjuvant chemotherapy and radiation, then chemo, then radiation, then observation. If we look at populations, we also see there's a potential advantage to radiation, this N2 patient population. This is a SEER database that shows, okay, admittedly just a smidgen of a benefit, but it's statistically significant for patients who get postoperative radiation versus those who do not. And also, if we look at a similar database from the National Cancer Database, we also see that patients who get postoperative radiation, they're not doing worse, and they do a little bit better if they have N2 positive disease, if they get post-op radiation, than if they don't. But none of these are prospective studies, and that's why there is this ongoing study, the LungArt study, that is looking for patients with N2 positive disease after surgery and randomly assigning them to postoperative radiation versus no postoperative radiation. So conclusions, and I'm down to a minute here. So adjuvant therapy. Strong evidence that 4 cycles of platinum-based chemotherapy following surgery for stage 2, 3A, and selected stage 1Bs is the standard of care. The only really defensible thing I think at this point to do beyond that is postoperative radiation, certainly if the margins are positive and it's not a complete resection, or if they have N2 disease. Stay tuned for targeted therapies and immunotherapies. I think targeted therapies do have a progression-free survival, most likely, but I do not know yet whether or not there is an overall survival benefit. And then refer patients for clinical trials like the Alchemist trial that will hopefully answer these questions for us.